That's my conclusion. Right. Are we ready to go?
Yes, we are.
Great. Welcome everybody to the session on ethics. This was done by request after the last ethics session. So we have 3 speakers this evening and myself, and we're going to...
Sorry, Jackie. Pride, please record the meeting. Pride, please record the meeting and make me co-host. Thank you. And make me co-host, please. Thank you, Jackie.
No worries. So I'd like to start off just by introducing our speakers, and I think I'll introduce all of them, and not just to their sort of high-profile CVs, but also say that I know these people and have had discussions with them, and these are some of the most ethical people I know. We have a great diversity. Dr. Edeling is a neurosurgeon who now works in medico legal, in the medico legal world. Dr. CP Van Eeden is a traditional medicine doctor who, again, works in integrative medicine, and his knowledge of ethics, as we saw in his last video, is outstanding. And Sipho is working in the nursing world, and again, she's from Zimbabwe but working in Namibia, and her knowledge of both medicine and ethics is outstanding. I think that I'm going to leave it there. I can go into more detail as we get to each speaker, but I would like to keep this time, given that the last session went 90 minutes, for an interactive session. Dr. Edeling is going to kick off with some slides, and then I think that we should move into questions from the audience and a panel discussion. So Dr. Edeling, it's over to you. Can we make sure Dr. Edeling can share screen, please?
Thank you, Jackie. I think I can share screen. Can you confirm whether you can see the share screen?
I can see it.
Okay. Well, thank you very much for inviting me. I really enjoyed the previous lecture of Dr. Van Eeden of this Intellectus Campus group, and it's an honor to have been invited this evening. May I just ask a question? The participants in this meeting, are they from Zimbabwe and South Africa? And is everybody a healthcare practitioner? Is it doctors, nurses? What is more or less the makeup of the participants, Jackie, as far as you know?
So, Herman, it's regional. So it should include Zimbabwe, South Africa, Namibia, Zambia, Botswana. And everybody on this group should be involved in the healthcare industry. They will be a variety of healthcare practitioners. Some will be nurses, some will be integrative doctors, some will be GPs. It should be an across-the-board group of primary care practitioners.
Okay, excellent. Thank you. So let me just say then, so in addressing people from different countries, I don't have knowledge of the laws or rules of countries other than South Africa. So to the extent that I say anything about laws or regulatory authority rules, that will be of South Africa. But of course, the underlying ethical and moral principles will be the same wherever in the world one is. So whatever I say about a South African law or a South African HPCSA guideline or rule, please bear in mind that in your country, it's probably similar, but make sure what it is in your country. My slides are a very short presentation just to create a backdrop. the topic that I'm addressing is medical ethics in 2023. The reason that I'm specifying the year of the medical ethics presentation is that there are incredible ethical challenges that I have encountered in recent times that I had never anticipated up to 2019. So having gone through very difficult times with the pandemic and all the rules and narratives and directives and prohibitions and everything that occurred, that has caused one to reflect deeply on fundamental ethical principles and the real meaning of ethics. So the first question is, as a healthcare practitioner, do you want to be ethical, or do you see ethics as an imposition, something it's really a nuisance and you don't feel like doing it, but they say you have to? If you see it that way, if you see ethics as an imposition on your freedom or an imposition on who you are, and you're a healthcare practitioner, then in my view, you're in the wrong profession. Because the healthcare professions are there to promote health of people. And you cannot promote health of others without being ethical. So ethics is the foundation of healthcare. There's no way that I can contemplate being an effective and authentic, a successful healthcare practitioner without being fundamentally ethical in your heart. So my personal approach to ethics has got nothing to do with rules that are written by anybody else. And that is how I would recommend healthcare practitioners view ethics. It's a fundamental part of who you are and what you are. It is something in your heart. It is something that is essential for your personal satisfaction that you are doing something meaningful in life. The reason we become healthcare practitioners is to do something meaningful that we believe in. If we don't do it in an ethical way, we won't believe in ourselves. So at the end of the day, the real reason for being ethical is for your own quality of life, for your own satisfaction and your peace of mind and your ability to sleep at night, to know that whether you made mistakes or not, but everything you did based on fundamental ethical approach to the relationship between you and your patients. Now, there are written laws and guidelines and rules. So here are the ones that apply to healthcare practitioners in South Africa. So first of all, the Hippocratic Oath. Fundamentally, that is an oath to say that I will treat my patients for their best interest, ignoring my own. And I will not cause any harm. And everything I do will be in their interest. There are other peculiar things about the original Hippocratic Oath, like teaching the children of your master without charging, etc. That is not really what the Hippocratic Oath is about. The Hippocratic Oath is about a fundamental oath to treat your patients with respect, dignity, and in their best interest. There's the Nuremberg Code that came about following the atrocities in the Second World War, which essentially says you can't experiment on people. In fact, you can't do anything to people without their informed consent. And you can't do anything knowingly harmful to people. So the Hippocratic Oath and the Nuremberg Code apply to everybody, no matter what country you're in. The Constitution of South Africa is the guiding law for all the laws of South Africa. And if you look at the Bill of Rights, the South African Constitution, you'll find that respect for all of the rights as set out in the South African Constitution accord completely with the proper view of medical ethics. So our Constitution is an ethical document. It provides for human rights and respect for others. It provides for freedom of choice. The South African National Health Act, number 61 of 2003, that is a law. So everything that is set out in that act, healthcare practitioners in South Africa have to abide by that. Because if you don't, then what you think you are doing is illegal. The ethical rules and guidelines of the HPCSA, that's the Health Practitioners Council of South Africa, those are not laws, those are ethical rules and guidelines. So the ethical guidelines are very useful and very good to remind people of how to behave ethically. The ethical rules are actually rules that if you don't obey them, you will be punished. You won't be punished by a court, you'll be punished by the HPCSA, either by having your license revoked or suspended or whatever punishment they choose to dish out. If one is participating in medico legal practice, which means using your medical knowledge to write reports for court and to give evidence in court, there are additional ethical issues that arise which don't arise in the course of normal clinical practice. And for those ethical issues, many of them are not covered in either the Constitution or the National Health Act or the HPCSA ethical rules and guidelines. So for that reason, the South African Medico Legal Association drew up a number of years ago a SOMLA code of conduct. So if you're interested in participating in medico legal practice, that's a very valuable document to obtain. It's available on the SOMLA website, setting out how a healthcare practitioner should conduct themselves when giving evidence in court in their relationship with clients who are not patients, but about whom they write reports, in their relationship with lawyers, etc. So that's just a list of where the rules and laws can be found. Now, I want to focus on the HPCSA ethical rules and guidelines, because this essentially is a talk about ethics, and in South Africa, our ethical prescribing body is the HPCSA. All of these are accessible at that website, www.hpcsa.coza/conduct/ethics. The only trouble is now, if I try and follow that link, I'm going to get something surprising, because it's not going to give me anything. I beg your pardon? Hello?
Herman, there's a problem with the muting. I've only been given the option to mute all, which means I'll mute you. So okay. I'm going to ask people who are joining to please mute themselves, and Pride, can we please mute everybody who joins?
Tell me when to proceed, Jackie.
Proceed. I think we've managed to mute the joiners.
Okay. So I'm going to go back to the share screen. When I tried to follow that link, which I just showed you, I got this server error in application. And the reason for that is today, the South African HPCSA website is dysfunctional, it's down. So you can't get there. Now, there are 17 booklets which contain all the ethical rules and guidelines of the HPCSA. It's a tremendous amount. It's probably worthwhile for every healthcare practitioner to read all of them. All of them are not necessarily relevant. I want to show you here what the 17 booklets are. So the first one, General Ethical Guidelines for Health Practitioners. That is relevant to everybody. Then booklet 2, Ethical and Professional Rules. That's relevant to everybody. National Patients' Rights Charter. Professional Self-Development. Guidelines for making professional services known. Guidelines on over-servicing, perverse incentives, related matters. So those are relevant to all practitioners. Now, for example, ethical guidelines for health researchers, that would only be relevant to people who are involved in research. Also, biotechnology research, research development, use of chemical, biological, nuclear capabilities. So you'll see that some of these are not necessarily relevant to your practice, but you will find all of them there. Now, to me, the most important document, because it really summarizes everything, is booklet 1. And in booklet 1, there are 13 foundational ethical guidelines, just overall guidelines that are relevant to bear in mind. And these set out the principles of medical ethics: respect for persons, best interest, non-maleficence, not to do any harm, best interest or well-being, beneficence, doing what is good, human rights, autonomy, integrity, truthfulness, confidentiality, compassion, tolerance, justice, professional competence and self-improvement, and community. Now, if you look at this, Jackie, do you see booklet 1 on the share screen?
Yes, I do.
Okay, so that's the HPCSA booklet 1. And if you go down there, they give a bit of a preamble, and then here there are those principles that I've just read out to you. And for each principle, they give a little explanation. I don't think it's necessary, and there's not much time to go into all of those, but if you're interested, please look at that. Now, what I really want to get to before we get to the questions and answers is that if you study all 17 of those booklets, if you study the South African Constitution, if you study the Health Act, the Hippocratic Oath, the Nuremberg Code, and you think about it all, and you try to distill that into what is it that really makes a practitioner ethical. What are the core values of ethical practice? I believe one can distill the whole thing down into 4 core values. And I believe that any practitioner who deeply believes in and accepts and lives according to these 4 core values will never be able to make a mistake in terms of ethics. And here are the core values. This is not from any authority. This is my opinion. You can disagree with my opinion, but this is my opinion. That if you live according to these values, you'll be fine. But only if you really believe them. And the values, the first one is truth. The second value is reason. The third is respect. And the fourth, and the most important, is love. So I would like, in the discussion that is to follow, I would like anybody who believes that one can be ethical without living according to those 4 values to explain that, because I may be wrong. But to me, if you always adhere to truth, if everything you conclude, every advice you give, all the thinking, analysis you do is rational, in other words, logical. If everything you do shows respect, not only for other, but for nature, for yourself, for everything, and you do it all with love, I don't think you can go wrong. Thank you, Jackie.
Thank you, Herman. As always, a brilliant presentation. I'm not sure if CP and Sipho want to add anything further to that, or whether we're ready to open everything to the floor.
I think it's such a beautifully packaged concept, those last four things, and it just reminded me immediately of the Metta Sutra, which starts with the words, "May all beings be happy and at their ease." And that's kind of the embodiment of those things as well. So it's beautiful that it's almost a universal concept that we have some of us have forgotten.
Thank you.
Sipho, do you have any comments?
Yes, I do. Thank you very much. Good evening, everyone, and thank you for having me. I totally agree with what Dr. Edeling has just said and the other colleague. And as healthcare professionals, we have to be guided, or it's a must that we are ethically guided in all that we do to serve the community, the lives that are in our custody, and never lie when we have done something on a human being. Veracity, like Doc said, is very important. You can't lie, I have done this for a patient, when you have not done it, or lie to cover up a colleague who is errant, because you then become, in the law factor, you then become an accomplice. And we can't do that with humanity. We have to respect human life all the time. Beyond any doubt, we should be reasonable, like Doc said, and we must make informed decisions all the time based on what the patient is presenting with and all the analysis that is done during treatment. And nobody should move the other person to do the wrong thing. We should all stand our ground when we look after the vulnerable who are sick. That's me in summary.
Thank you. Thank you very much.
Thank you, everyone. So one of the topics for this evening is what is the difference between what the law says and what ethics say. And I think all of us in the last 3 years have been in a position where, in order to follow the regulators and those that impose the law, we might have found ourselves in a position where we felt that what we were doing would be unethical were we to follow the rules. The most illogical, I love the part where you talk about reason, because in my mind, when this whole thing kicked off with infectious disease, and I think we understand infectious disease in Africa, when people started saying do nothing when someone was suffering from an infectious disease, go home and come back to hospital, which was the hospitals were woefully inadequate at the time. It made absolutely no logical sense. And the fact that people were following rules rather than reason was something that I found quite new in the world. I trained in a very different world to the world that I found myself in when a lot of this happened. So one of the things I'd like to sort of bring up is, as doctors who have treated malaria, we know that early treatment is essential. if we don't want a patient who ends up in ICU. As doctors who've treated HIV and Helicobacter, we know that intracellular organisms need combination therapy. And one of the things that I'd like to raise just as a subject is, what do you do when your reason and your logical analytical skills are opposed by laws and rules imposed by people who are not in your own country, not in your own continent, and not actually seeing patients at the front line? And going forward, should we be ensuring that people at the front line are involved in establishing guidelines? So I'd like to throw that out to all three speakers as a question.
Jackie, I think seeing I spoke first, I should go last in response to your question.
Okay, let's put CP on the spot.
Thank you for that. So you're not holding back any punches, and we immediately go to some really challenging and deep things. So for me, it's not as easy as saying just do what you need to do, because we do know that there are also repercussions, and a challenge with those repercussions is that if you were to get into trouble and you lose your license, how many patients will suffer ongoing because you cannot help them? So it's to me an extremely fine balance of where do we push and where do we know not to push. And on all accounts, it's wrong, because that goes against those four elements that Dr. Edeling shared. So for me, there would be a big focus on public education, on getting the people involved and knowledgeable, not. Shall we start again?
No, you were only muted for a little while.
Okay.
Are you unmuted now?
Yes. So a thing with that is, let's educate the public on what is needed, so that it becomes a global awareness, rather than just practitioners standing up for the people who need to be part of our voice.
Okay, great, thanks. Am I unmuted? Sipho, what's your take on this?
I believe in empowering others, especially the sick, on what is wrong with them. Give them all the information and the choices that are there for their treatment. Don't force any treatment on a patient. As medical practitioners, we shouldn't be paternalistic. The patients have a right to autonomy, make their own decisions, give them all the information. And there's an act in Namibia crafted last year, access to information. We give people the information so that they know what is running around them. And this business of, if I don't do this for you, you will die, you will deteriorate, you won't make it. Give them the option so that they have a clearer picture of what's happening to them. Use simple language that people understand about their bodies. And we must remember, by the time they come to hospital, these people we are nursing or looking after have lived in their bodies for a very long time, and they know exactly what is wrong with them. Let's listen to them to understand what's wrong, not listen to answer and give our technical expertise on what's happening. Yes, they've come to us, they want to be helped because they are under the weather. But let's not judge patients. And remember, hearing is the last sense that is lost in anyone's life. Even the unconscious will still hear us. When they come round, they'll tell us, you were saying this, you did that to me, and you were unfair to me, or you left out information that was necessary for me to make a decision. And I know there's a pandemic, info-pandemic, I'll call it, about what's happening to the human body. People can just press Dr. Google, will tell them this and that. By the time they come to the hospital or to any medical practice, they partially know what it is that they want done, or what it is that they think is wrong with them. Let's not brush them off and say, well, I went to medical school, I went to nursing school, I was in the pharmacy faculty, so listen to what I'm saying. And remember, we want them to buy into their medication and the treatment course. We want them to be compliant when they go home. And when we admit them, nobody stays in hospital forever. We are going to discharge them back into the community. Let's engage the family that is going to take care of those people, and we listen to everyone. We mustn't listen to answer, but listen to understand what is wrong. And in health economics, we shouldn't forget also going all the way and doing some unnecessary investigations, or medication maybe that's prescribed, maybe the patients do not afford. Talk to the family and see what it is that they can afford, and then we can always have alternatives. And if we always push things down patients' throat, we get some resistance, or they'll move next door to get help. And you want to maintain a mutually beneficial relationship with the clientele so that they can come back, have all the trust on you, and they can never hide anything. They'll tell it all the way, and we work as a team with the patient. We mustn't exclude the patient who's the central or focal person in healthcare.
Thank you, Sipho. Well said. And I'm going to quote what someone in the audience has just said. I love what Sipho is saying. Practitioners have lost the art of listening to patients, listening to understand. So before I go on to another question, I'm going to get your opinion, Herman, on, well, you're generally pretty good at giving your opinion, so I'm going to let you fire away.
Jackie, I'm going to just address something that I think I heard in your question, and you can stop me if you didn't intend this. But what I heard you expressing is something that I've experienced very acutely over the past recent time, which is that the very organization, the council that is there to go to monitor and supervise our ethical practice is behaving apparently in unethical ways. And that has presented for me a tremendous ethical dilemma. So we are, for example, to practice truthfulness. When we become aware of rules being forced on us and on our patients based on an untruthful interpretation of data about which we know, what do we do? And I know what you did, Jackie, you know what I did, but that is an extreme ethical dilemma when the authorities are behaving in ways that are unethical. So I don't think I need to go into that in any detail, but my own personal response to that would be to say, well, my primary duty is to the well-being of patients. And as stated in the Hippocratic Oath, not only those patients who come to me, but the community as well. So I think as healthcare practitioners, we have an ethical duty to our own patients and also to the community. And if we become aware of something, even if it's a law, even if it's a regulation, even if it's whatever any authority has put out, but we have sound reason to believe it's harmful to patients, then I think we should have the strength to stand up and say that. And as Jackie did, when we know there's a treatment that we are aware of that will help patients, will save lives, and will save suffering, even if the authorities say we mustn't use that, ethically we must use that. Thanks, Jackie.
Thanks, Herman. And getting back to one of the questions on the group, can you explain the roles of guidelines and protocols versus ethics? Can our reason be personal and still be ethical when we are giving medications which have no evidence of safety and efficacy just because we are in a crisis? And I can probably answer some of that. I think that when there is a crisis that involves something novel, then we cannot be waiting 2 to 4 years for double-blind placebo-controlled trials to show that something has level 1 evidence of safety and efficacy. I think the most important thing is to use reason and logic. And the reason and logic that we used when we had 17 ICU beds in the whole of Zimbabwe was we knew, just like Dr. Zelenko, Dr. McCulloch, Professor Barodi, doctors all over the world, we have known since the 90s with HIV that anything that puts zinc into a cell will stop an mRNA virus from replicating. And treatment protocols based on that included hydroxychloroquine, zinc, doxycycline, chloroquine, quercetin, and ivermectin, all of which had very, very, very well documented safety profiles. The hydroxychloroquine is completely safe even in pregnancy. Ivermectin, it's almost impossible to kill yourself with it unless you drown in it. And the only person that I know who actually successfully killed themselves in a study with it took 660 milligrams together with warfarin. So I think the most important thing when we're facing a crisis or when we're facing something where we can see that a patient may not make it, we must first look at safe medications that would logically treat whatever we're facing. So I would not treat a patient with malaria with ceftriaxone because I wouldn't expect it to work. However, if I've got a highly suspicious case of malaria, I might not have the test back, but I know that Lumaten is safe. I know that Coartem is safe. And therefore, even if I am not 100% sure because I haven't got a malaria test, I would still do a risk-benefit analysis. And the bottom line is that the risk of many of the repurposed medications was absolutely minimal. And one of the things we seem to have lost in the last 20 years is the critical care mentality that a lot of doctors trained in my era were trained with, which is make a clinical diagnosis, send off the confirmatory test, but in the interim, treat the patient. So many junior doctors these days will not treat unless they have a confirmatory test, and they don't understand the concept of false negatives and positive predictive values. And if something is safe, my question would be, if not, why not? And if something isn't working, reassess your diagnosis and pivot. And that would be my answer to that question. I'm not sure if anybody else would add anything to that.
Yeah, Jackie, I think that's very well said. I just like to focus on one issue in that line. You spoke about the need generally for level 1 evidence, so we know exactly whether things are safe and effective and so on. But there are many, many circumstances in medical practice for which there is no level 1 evidence. I know in my whole career as a neurosurgeon, many of the decisions that made, there was no level. Now, can I carry on?
Yeah, carry on. Pride, can you please make sure all the participants are muted? Can everybody please mute themselves? Thank
Yes,
you.
I'm doing my best to mute. If I mute someone twice and you keep on muting, unfortunately, I'll have to put them in the waiting room.
Carry on, Herman.
So a very good example of this occurred in the coronavirus pandemic, because the messaging that we were all told, which put us all into a state of fear, was that there is this deadly new virus pandemic which is going to kill people and maim people, but there's no treatment. And the messaging that we received was, if you get sick, just stay at home and do nothing. And if you get better, that's fine. If you can't breathe and you become blue, then go to hospital. And then we soon found out that when you go to hospital, you then get ventilated and then you've got a good chance of dying. And the messaging was, there is no treatment. Now, when it came to my attention that there were people saying, like, for example, Pierre Corey and Tess Laurie and Paul Marrick were saying that ivermectin is useful for prevention and treatment of COVID. Now, yes, granted, there were no level 1 long-term safety and effectiveness trials for ivermectin in COVID-19 because there hadn't been enough time. It will take 10 years for there to be real level 1 evidence. But if you consider the safety of ivermectin, which was very well, there's very, very good evidence that ivermectin is very safe, as Jackie said. So whether the effectiveness is 10% or 20% or 70% doesn't matter. If I know that there's something which in this panic where they say nothing will help, but here Pierre Corey has told me, try ivermectin, I'll try it. And if I have a patient with COVID, I will give it until such time as I hear of something better or safer or more effective. So that is where the reasoning comes in. One must exercise clinical judgment in terms of the magnitude of the threat, the risks of doing nothing, and the risks and potential benefits of doing something. Even if it is not properly tested, if it is very safe, it's probably best to use it. And that's a very important principle in many medical or therapeutic interventions, where we employ methods that we know are safe. We're not altogether sure they'll work. We're not sure whether the benefit is 10% or 50% or 90%, but it's better than nothing. We have to have the courage of trust in our adherence to truth, reason, and decision making. Thanks, Jackie.
Thank you, Herman. I'd like to refer people, there's a brilliant paper, and there'll be a second one coming out shortly. And I cannot pronounce his name, but Dr. Eleftherios Goukolakis did a very good paper with Dr. Zelenko and Dr. McCulloch. And what he has done, and it's a very useful paper, I'll share it on the group a little bit later. But what he showed, or his question as a professor of mathematics, was the Zelenko protocol, which was hydroxychloroquine, azithromycin, and zinc, better than doing nothing? And there was absolutely no question that the original Zelenko protocol from March 2020 was 3 times better than doing nothing. And that statistical model can be applied across all the different protocols. And with many of the protocols, with many of the people that were treating early in 2020, there was up to a 10-fold difference between combination therapy and doing nothing. And I think that we should be, as doctors, we should be very careful in the future about being divided over many of these issues. And as you know, the story that came out earlier today, that the British Medical Association has put out a vote of no confidence in the General Medical Council. I'm quite sure that's not going to make BBC News, because the media have been totally complicit in this entire thing, and I think that they've misled the public. But nonetheless, it's got to the point where doctors in the UK have united and said that the General Medical Council should all be dismissed. And I think the rest of the world may follow suit, because doctors are being asked, when they are faced with clear and reasonable data, that they are being ordered to do things that are unethical. Doctors are starting to get tired of the way that the doctor-patient relationship has been abused, because the doctor-patient relationship involves an enormous amount of trust. And right from the very beginning, I think that doctors were pushed, and not just doctors, nurses, every healthcare practitioner was pushed into doing things that we know were ethically wrong, because the data was there by December 2020. And the doctor-patient relationship was used to convince the public of safety and efficacy of certain treatments, and that other treatments were ineffective and horse medicine or various other terms. So as a group of healthcare practitioners, what can we actually do to stand up against people who are in authority? And as you said before, Herman, it's authority versus science. There are many people who use their positions of authority, but they will not debate, and they cannot logically explain why they are advising certain things. And what can we do as healthcare providers in order to stand up against this?
So, Jackie, I just want to comment on something that you said earlier on with the doing nothing versus doing something. There's one thing that's really important that we need to highlight there as well, is that doing something gives hope. And when we have hope, we have much better outcomes. Just on the patient's approach to life. And then on the doctor-patient relationship, the challenge is to get that choice, because as practitioners, each one in their own field, you are trained to make decisions. You are not necessarily trained, that wasn't the training that we had, to follow a flow chart. You are trained to use your brain and make use of the knowledge that you have been given in order to then help the patient in their unique set of circumstances. So those were just two quick comments. The standing up, again, from my side, it is sharing knowledge, not keeping the information or the facts, the science hidden up in obscure journals, but actually talking to people about it and making people aware of the science that is readily available. And yeah, ground roots education.
Thanks, CP. There's a couple of questions in the audience. There's a question from Kai. There are laws that can seem unethical, even though they are law, and she mentioned, or he or she mentions, that at one time slavery was law. The comment is, I would like the panel to advise on consent, whether it's for surgery, for patients who can't, for whatever reason, give consent. What does the law say about next of kin being able to give consent? And this is probably a question for Herman, because he's the medical legal expert.
Okay, so let me deal with the consent question, Jackie. The principle is that the patient, if he or she has mental capacity, is the one who must have decision-making authority over their own life and their own body. So another person cannot make consent in the stead of the patient if the patient has mental capacity. However, if the patient is a child, or if the patient's mental capacity is hampered by being drugged, sedated, or by being semi-conscious or unconscious, then obviously they cannot make a decision themselves. Now, there is, and in South African law, it's very clearly stated in the Health Act, for example, the concept of next of kin. So the simple rule of thumb, if Mr. Smith cannot understand or give consent himself, then his next of kin is the one who must make the decision. Now, there's a line of succession in terms of next of kin, and it's important to know what that is. So if a person is married, then their spouse is automatically the next of kin. If the spouse is dead, or the spouse is not available or can't be contacted, then the next of kin is an adult and mentally capable parent, or an adult and mentally capable child. So if it's a young adult, say now 22-year-old, then of course their parent, which could be their mother or their father, would be next of kin. If it's any one of us, we are advanced in years, then our adult children. And in terms of children, it would be the firstborn and then the secondborn, etc. So the line of succession of next of kin is spouse, and then your eldest child, your second eldest child, etc. That is what the law says. But there's a very important thing to bear in mind when difficult decisions have to be made. Like, for example, instituting ventilation, terminating ventilation, resuscitating a person who's got a very poor prognosis. When there are life and death decisions, the law says we'll identify that particular person who can make the decision. Now, one is often aware that there's disunity in the family about what to decide. So the spouse might not be the parent of the children. The spouse might be a subsequent marriage. And there's disunity and disagreement between the spouse and the children, or between the spouse and the parents. And the best approach is to identify who is the decision maker, who is the next of kin, and then to speak in one meeting to that person plus everybody else of the family who has an interest, and try to get them to a consensus decision. Because if that one person says do something or don't do something and the others disagree, at the end of the day, the doctor will be caught in the middle of them. So I often had this situation doing brain surgery, and the thing that helped me the most was to identify next of kin, but speak to everybody and try and just through not persuasiveness, but just through telling them the real facts, and being respectful to everybody and respecting everybody's dignity and their fears and everything. Generally, when you tell the truth to the whole family, then the whole family is generally willing and able to come to a sensible consensus decision.
Thank you, Herman. One of the things that I did learn while I was working overseas, in Australia, when you are 75, you have to have a medical. And in that medical, part of the medical is to appoint a medical power of attorney. So while the patient is still of sound mind, and it probably should apply to all of us, whether we're 50 or 40 or any age, what you do is you appoint someone who, in the event that you are incapable of making a decision, either through a brain injury or hypoxia or a car accident or whatever, that is the person that would follow your wishes. And I have a story from Australia of a patient who was from Latvia who had 11 children. And when she was in a state where she had zero quality of life due to dementia and bed sores and a multitude of other problems, one of the children stood up very fiercely and was adamant that we should treat. And it turned into a 3-day very traumatic event, which would have been avoided if she had signed a medical power of attorney earlier. And it is something that interests me in that in Africa, it's very rare to have a patient who has done that. People will do a will, but they don't appoint someone to make decisions for them if they're incapacitated. I'd just like your opinion on whether we should be, in all of our patients, promoting that they do give medical power of attorney and specify who makes the decisions in this kind of a situation.
Jackie, I'd just like to answer briefly to that. The concept is a very good concept, that while the person is of sound mind, they decide who will make the decision in their stead. The only thing that I've discovered fairly recently is that it's not a power of attorney, because I believe a power of attorney is only valid while the giver of the power is of full mental capacity. So if I give you power of attorney and I lose capacity, then the power falls away. So it's another legal instrument. And it is the instrument that I'm aware of is what's called a living will. So in which you write what you would like to happen under circumstances, and if you don't have capacity, and who you would like to make decisions on your behalf. Now, that, to the best of my understanding, is not a legally binding document. So it can't force a doctor to do something, but it is a powerful document, because if a doctor goes against the wish of the person that you advised or against the wishes you've expressed, then the doctor can get into trouble. So I would rather ask an attorney or who knows what the law stipulates about that. But the best legal instrument for achieving that, so that if I'm unconscious, the doctor must listen to my wife as if it's me.
Thank you, Herman, for that.
Sorry, Jackie, I just saw another question about siblings. I'm not sure what the position is of siblings in South African law, whether they take precedence over children or parents. I don't think so. I think it's spouse, parents, children, but I think siblings come after parents and children in in the line of authority.
Great, thank you, Herman. I've got a direct message to me from someone who's on the call. And the comment is that in terms of evidence-based medicine, the person who first in 96 discussed evidence-based medicine created the concept in order to support the clinical.
Let's have.
Please can we mute? So the three pillars of making a decision that will give the best outcome to the patient are, number one, the experience of the clinical treating team. Two, the best available evidence. And three, the choice of the patient. And I think that that probably sums up a lot of what we have said. I think patient choice has been severely neglected in the last few years. I think that experience-based medicine, which is Professor Barodi's favorite saying, is something that has also been discarded, especially in terms of frontline clinicians. And the best available evidence needs to include all evidence, from case histories all the way through to level 1 evidence. And the comment that has been made here is, do you know how many patients were treated with penicillin before it was rolled out in the Second World War? And the answer is 1. And I think that's a very important comment to make. I think that the experience of the clinical team has been neglected and patient choice has been neglected, because at the end of the day, the patient must be autonomous and must be given a number of choices, which, if they are of sound mind, they must be able to decide what is the best treatment for them in that situation. So thank you for the person who sent that to me. Dr. Landman has asked, what does a doctor do if one subspecialty, in this case GPs, who are treating COVID on the front line are being stopped or openly criticized by another subspecialty, as public health physicians and internal medicine specialists, on treatment of the same patient? And I think that's an important question, because I think a lot of specialists perceive that the GP or the nurse is below them in terms of decision making. I'd love to hear Sipho's opinion on that, in terms of how do you feel when you are caring for a patient and somebody above you overrides you?
Thanks for that question, Jackie. I think doctors shouldn't be fighting over patients. Yes, we need to be guided by others when we are looking after patients. If a GP is spoken to nicely and ethically without undermining them, that we need to call in a specialist. We've seen that you've been treating the patient for so many days, but there's no change. Or maybe the family feels they want a second opinion. Let's grant it to the patients. We should be fighting in the earshot of the family and the patients. We can do the background checks out of earshot of the patients, because all we want is a patient to get better. And remember, when we are looking after a patient, it is not who has done it better or who is doing it best, but we are taking the best interest of the patient, so that at the end of the road, best medical practices have been achieved. We send a patient home to go back to their normal life, as near normal life as possible. And remember, medical aids pay specialists at a certain rate and GPs at a certain rate. After a specialist has stabilized a patient, they will discharge them at some point. And who do they discharge this patient to? Back to their GP, who's their family doctor that they are better known to. And it's not anybody's fault to deteriorate and then need an expert's opinion or intervention. This should be clearly explained to the patients so they understand. And I think the way that we talk to each other as healthcare workers or healthcare practitioners actually matters most, because if you downplay your colleague, the patient loses trust in somebody who's been looking after them, maybe has saved their life before a specialist came in. So we really need to be careful when we are talking to each other, and no wars in front of patients. Healthcare practitioners must remain ethical, and our misunderstandings can be sorted out after we've stabilized a patient. And we must remain as professional as possible. I've witnessed instances where people pick fights in front of colleagues or patients. It's not right. And remember, we are not doing any harm, but doing good to any patient. Those 4 pillars that we talked about on ethical principles. And if we are guided by ethical considerations, we shouldn't be faltering. Everything that a patient so deserves must be patient-centric. Yes, the GP is not getting the patient better. We need expert step-up of the medication or interventional medicine or whatever. Let's do it in a harmonious way, effectively communicate without hurting each other. Tomorrow we'll still need each other. And I would want to recommend that specialists write back to GPs when they've had referrals and vice versa. Communication is very important so that there is a robust, integrated sharing of medical legal information. Of course, we uphold all the other principles. We shouldn't be fighting for the sake of the dollar over a patient. It's the patient's interest that we put first. That's my point.
Thank you, Sipho. Jackie, I'd like to just chip in here and say that I agree very much with everything Sipho has said. So thank you for stating it so clearly. I would like to add another perspective to this, because it comes down to one healthcare practitioner criticizing another one. In general, healthcare practitioners should not criticize each other, but there are circumstances in which it is necessary, because they may hold very different views about the treatment. Now, there are certain ethical principles that I think both involved in such a dispute should bear in mind. The first thing is to play the ball and not the man. So it's not, okay, I'm a neurosurgeon, you're a GP, so therefore I'm right, and you must run away, and whatever I say is the right thing. That's playing the man. And that is wrong. It's unethical and it's unscientific. It's unprofessional. If I want to disagree with another doctor's treatment, then I have to say why. Not because of who that doctor is or because of who I am. It's got nothing to do with the importance or status of the practitioner. What it has to do with is the best interest of the patient. So if I were to say, yes, doctor, I know why you recommended that, but I'm concerned because of this reason, that recommendation of yours could end up with this problem. And because of that concern of mine, I would prefer to recommend this, which would circumvent that. And if you are talking the truth, and if there is reason, then the person you're talking to will also see the reason. and the patient will see the reason. Patients are very clever. They recognize the truth when you say it. So if you forget about me and them, or me and you, and we just focus on the patient and we focus on the truth, all of those things can be resolved. But I also want to point out a very important thing. Long before the COVID pandemic, I was regularly aware of places where a general practitioner made a better decision and got a better outcome than a specialist. And it's not necessarily, it doesn't mean GPs are cleverer than specialists or better, but any honest healthcare practitioner who is ethical and applies their mind may make a better decision than any other one. And in the COVID pandemic, I want to point you to Dr. Jackie Stone in Zimbabwe, Dr. Shankara Chetty in South Africa, Dr. Rapiti in South Africa, 3 GPs who said, to hell with what the authorities say, we will treat our patients the way that we know is best. And all 3 of them had incredible results, which specialists in South Africa and Zimbabwe did not achieve. So it's a very real thing that general practitioners can be more right than specialists. And I think that all specialists should have the humility to recognize that. And if I were to get into a dispute with Shankara or Jackie about anything, it wouldn't go about what is my status and what is your status. It would go about who's the patient, what is the problem, what do we know, what is the best scientific evidence we've got, and rationally, what is the best approach. And that way we can really avoid all conflict if we just make it about the science and about the patient.
Thank you, Herman, for that. And Dr. Landman gave a very passionate speech at the GP conference about putting the patient at the center of care. And if you put the patient at the center of care, then all of this really goes away, particularly if you apply logic as well. There are lots of questions now, but one of the ones I just wanted to bring in was the amount of money that it can cost at the end of life. And I can't tell you how many patients in not just the last 3 years, in the last 20 years, where patients have come in and they are almost certainly not going to survive, and enormous amounts of money have been spent on drugs like remdesivir and monoclonal antibodies. But it's not just those, it's been unnecessary surgery. And so the question is, why are some doctors putting money first instead of saving lives? And I would say that one of the things that it's very, very important to take into consideration at the end of life is if you have a situation where it is going to bankrupt the patient, the family, and everybody who is lending money to that family, and the outcome is very unlikely to be good. I think that it's very, very important that the discussion is had with the family as to whether heroics are warranted or not. And I know we're discussing some things that are very sort of close to the bone at the moment, but I'd like your opinion. And in neurosurgery, you must have faced this a number of times. At what point do you stop bankrupting the family?
Okay, so Jackie, it's not a point that I can decide. It's not a point that you can decide. It's a point that the family must decide. And the only way I believe that they can make that is we just go back to this basic principles of informed consent. Remember that there must be consent to give a treatment and there must be consent to stop a treatment. And informed consent also means they can refuse a treatment. So what always worked for me in terms of that was to say to the family, look, this is the situation. The prognosis is horrible. The possibilities are this and this and this. If we do this, this is possible, but it's far more likely that that will happen, and that will be the cost. If we do that, That will be the cost. It's possible this will happen, but it's more likely that will happen. And then when people ask you questions, because they always do, and they're always sensible questions, just answer them honestly, no matter how unpleasant the answer is, no matter how unpleasant the reality is. That's the real test of the courage to be truthful in the presence of serious adversity. Just be truthful. I can't tell you, Jackie, how many times I've cried because there's a terrible thing going on. Somebody is suffering, they're going to die. And the family asks me, and I give them bad news. And at the end of it, they thank me for telling them the truth. They didn't want to know, they didn't want me to tell them what I thought would make them feel better or would protect them from stress. They wanted to know the truth. And actually, people can deal with the truth. What people can't deal with is lies and pretense and secrecy. People can't deal with that because they lose trust, they don't know what to do. But tell any rational, sensible person the truth, then you empower them, because with the truth, they can make a decision. So that's unfortunately my only answer, Jackie. Be ruthlessly truthful all the way and let them decide when they feel the cost-benefit ratio is not worth it. And people will make that decision. They'll say, no, we realize that it's not worth it. We're not going to sell our house for something that might keep him alive for a week and he'll die anyway. They can make the decision.
Thank you, Herman. And I think the words we're looking for are integrity, courage, and conviction. And that is what medical ethics is all about. And as doctors, we don't often get a platform to talk about these kind of decisions. And I'm very grateful to everybody who's been on this panel for being as truthful and as honest as they have. So thank you, everyone. I see we're already over time. And if there are any other burning questions, please let us know. There are further questions, including the religious questions. And my answer to that is, in my experience, if you cannot transfuse a patient because of religious reasons, and you want to override that if it's a child, you actually have to go to the courts, which takes a very long time. So that's an answer to the question of what to. The answer is, sometimes as a doctor, there's absolutely nothing that you can do, particularly if it's at night and the court is not open. So another comment, empathy is what Sipho is talking about. And if you follow the value of love and respect, as said by Dr. Herman, empathy comes in the mix. Sipho's views are refreshing, and I would agree with that. So unless there are any other burning questions, or unless anybody else wants to make a comment, I think we should start closing it down.
Jackie, I just want to add to what Dr. Edeling said on end of life and when do you stop. To me, it is also important that when we look at that, as well as the idea of the specialists versus the GPs and versus each other, that we need the narrative to change firstly there, so that there is an acceptance of a multidisciplinary approach to the patient outcome, to the healing, whatever that healing might be. And then included in that, when you do reach that stage where the patient starts talking about, okay, do we stop therapy, or the family starts talking about that we then include access to counseling. Not all practitioners are great counselors, and we don't expect practitioners to do everything. Not everybody will and can do everything. But then to have somebody sit them down after you have given them the information and then say, right, let's take a breath and then let's discuss in a still safe space, and so that people can then unpack as well. there's the unfortunate thing that's still very prevalent, that the doctor is seen as a deity. And so people are oftentimes not willing to break down or to then discuss their deeper challenges in front, because I have to be strong for the doctor or I have to be strong for the patient. And so to me, it's really important to then have the team set up and to break down the silos of specialization and of practice.
Agreed. Thank you, Dr.
Thank you, CP. Very well said. Right, so if there isn't anything anyone else wants to say, I'd like to close it there. I'd like to thank everybody for a really informative discussion. And I think we need more forums to be able to talk like this, because I think a lot of very ethical GPs have felt as though they've been sort of vacuum packed in isolation for a long time. So thank you, everyone, for your contributions.
Thank you, Jackie.
Thank you.
Jackie, one word from me, may I?
Absolutely.
Dr. Jackie, just a reminder that before sorry.
Public confidence by being ethical in everything that we do, no matter what time it is, no matter what rough a day we've had, we still need to remain professional. And may I appeal to us all that every country on earth has a patient charter. Other ministries display their client service charter everywhere. Why don't hospitals display patient charter so we empower our patients to know their constitutional rights and what each Ministry of Health stands for when we are looking after patients? I'll be a happier person when I see patient charter displayed in every hospital public area, including doctors' practices. It will give the public confidence that we are treating them under ethical conditions. Thank you.
Thank you, Sipho. Obi, you've raised your hand.
Dr. Jackie, thank you. I think just an extension of gratitude to the panelists, to the great degree that the discussion had really allowed one to understand medical ethics for one who's not a healthcare practitioner. So kudos and gratitude for that. I just wanted to make a reminder as well to say, please, for all of the colleagues who have joined the session, to please remember to complete the details on the link to enable intellectors to issue certificates for this panel discussion. It is going to be a CPD accredited session, and definitely looking forward to panel discussions such as this. Thank you, Dr. Jackie, for moderating, and to the panelists for making the time. Thank you.
Thank you, everyone, and thank you for your passion. All three of you are incredibly passionate people, and irrespective of what your very impressive CVs say, I would say that is the quality that I admire the most in all three of you. So thank you.
Thank you, Jackie.
Thank you.